On behalf of Instrumentation Laboratory, I'd like to welcome to the AACC Industry Workshop on clinical impact of sample quality and the value of automating pre-analytical quality assurance in hemostasis testing. So today, we have a very distinguished speaker in the program, Dr. Andy Winkler. Following Dr. Winkler's presentation, we'll have a technical presentation by Mr. Jack Havlick, who's an IL R&D scientist. You'll have the opportunity to ask questions of these experts in the Q&A portion, which will follow the last presentation. So today's workshop will help you identify and understand the most common sample pre-analytical issues that are associated with hemostasis testing, review the current guidelines related to sample pre-analytical issues, and discuss the newest technologies that automates the detection and management of samples with pre-analytical issues. Now I have the pleasure of introducing our first speaker, Dr. Andy Winkler. Dr. Winkler was an assistant professor in the Department of Pathology and Laboratory Medicine at Emory University. She was the medical director of the transfusion service at Grady Health Systems and the assistant medical director of the Emory Special Coagulation Laboratory. I'm very pleased to announce that Dr. Winkler was just very recently joined Instrumentation Laboratory as our Director of Medical Affairs. Dr. Winkler?
Thank you very much, John, for that introduction, and thank you all for being in attendance here this afternoon. So what I hope to discuss with you today, or at least review with you, is pre-analytical effects in coagulation testing, and hopefully setting the stage for Jack to introduce our Top 50 series, which introduces some pre-analytical checking. So if we talk about quality in laboratory medicine, it's typically defined as the guarantee that every step throughout the total testing process is correctly performed. So that assures valuable medical decision-making and patient care. So in the past decade, we've been able to have at least a tenfold reduction in analytical error. And that's really been due to improvements in the reliability and standardization of analytical techniques, reagents, and instrumentation. So overall, the current rate of laboratory errors is established to be at nearly 4.6 sigma. And that's improved from the previous years in 2007, as you can see here, and in 1997. And this is better than having the risk of losing your luggage at the airport. So the risk of us making a laboratory error is less than what Delta is going to lose when you check a bag. So several lines of evidence, though, suggest that most errors in the total testing process fall outside of the analytical phase, so fall outside our control in the clinical laboratory. And it's really the pre- and post-analytical processes that are most vulnerable to laboratory errors. So if we talk about the testing life cycle, the amount of automation and process controls that exist in the analytical phase, it's become apparent why this is really the case. And so we have no control in the laboratory of the pre-analytical steps from when the patient visits their physician to when the physician orders the test to when the sample is collected. In the pre-analytical phase, from that sample collection to when we receive it in the laboratory and put it on the instrument. In addition to the post-analytical phase where we release the result, the doctor interprets the result, and then treats the patient. So it's been estimated that 32 to 75% of all testing errors occur in the pre-analytical phase. It's important to know that not all pre-analytical errors cause adverse events because many are caught or they're minor enough that if they're undetected, they don't actually impact patient care. However, there may be unnecessary risk to the patient and unjustifiable cost to the healthcare system. So the pre-analytical challenges that can occur with any specimen in the laboratory can be multifactorial. So it can occur because of problems in sample collection, and that can be actually the collection device and the size of the needle that's used to collect that specimen, the site, if a discard tube is used, what the order of draw is of the tubes, and if there's prolonged venous stasis. But also a big problem could be incorrect specimen labeling if a bedside barcode device isn't used. Errors can also occur with sample mixing, anticoagulant type, the tube that's used, of course, the cap material, so if you have a cap piercing analyzer, that can make a difference, sample transport, storage, processing, and then the sample quality checks, which are really going to be the focus of this presentation. So specifically, things that impact us many times in the coagulation laboratory are clotted samples, underfilled tubes, hemolyzed samples, those that are icteric, or those that are lipemic. So we look at all pre-analytical errors in the laboratory. There was a study that was published from the University Hospital of Padova in Italy looking at their STAT laboratory. And so in 3 months, they reviewed over 51,000 analyses in their lab. And so what they actually determined the rate of a pre-analytical error to be of all errors was 61.9% of all errors were pre-analytical. Most of those, 13.1%, were tube-fill issues. And what they determined was that over 90% of these could have been preventable. But I think the biggest impact was that over 24% of these laboratory errors affected patient outcomes. 16.9% of those required laboratory test repetition. 5.6% further inappropriate investigation, so further inappropriate testing. 1.3% resulted in inappropriate transfusion, and 0.6% resulted in inappropriate intensive care admission. So there definitely is an impact of the pre-analytical errors as far as patient care. Not only is there substantial inconvenience or risk to patients, but there's also cost issues. So there's been a model developed by healthcare economist Frost and Sullivan in consultation with BD, and this model was developed to quantify the cost of poor blood specimen quality on total operating cost of patient care. So to date, this model has been applied to 7 hospital organizations in 4 countries, and the countries represented include US, Canada, Germany, and Ireland. The estimated average cost of a single error in North America was $208, but it differed by patient type. So most expensive was outpatient, which included the ED, so that cost increased to $337 and was less for other settings, maybe where the patient was being redrawn more frequently. But if you can imagine having an error having to be redrawn and have that patient actually come back for a subsequent phlebotomy visit, does have significant costs associated with it. Not only is it cost, it's also patient treatment costs in hours. So the pre-analytical specimen error cost, if you look at total hospital budget, represents 0.23 to 1.2% of total operating cost. So if you extrapolate this to a 650-bed U.S. hospital, that's over $1.1 million per year. So the costs accumulate. If you look at the breakdown of the cost, most people would think that the redraw costs, the second bar here, would be higher. But really, it's the patient treatment costs that are most. And so it's been estimated that over 24,000 patient hours, which may be from redraw or treatment, were lost in an 850-bed hospital in 1 year. And 90% of those were due to patient treatment. So specifically in the hemostasis laboratory, there's been a publication, a study at the University of Verona, which is a large hospital, 750 beds, looked at 2 years of errors in the laboratory. So pre-analytical problems were identified in 5.5% of all routine and stat coagulation samples. However, one of the things you may notice, but it is small in this print, that the most frequent error was actually not receiving the sample. So once you exclude those, so of the samples received, pre-analytical problems accounted for over 60% of their laboratory errors. So that's what's been demonstrated in the hemostasis laboratory. Of those, the most frequent event is hemolysis. So hemolysis occurred in 19.5%. Clotted samples, 14.2% of the time. Contamination, 1.1%. And icterus and lipemia occurred in 0.3% each. So the most frequent event that we see in the hemostasis lab is hemolysis. So we're going to go through each one and talk about the importance of them in terms of hemostasis. But for fill volume, this is extremely important because coagulation tubes, as many of you know, have a peculiarity when compared to others. And that's because of the anticoagulant we use, sodium citrate. So you have to have the appropriate filling volume of a ratio of 1 part citrate to 9 part blood to be able to be properly anticoagulated, because the underfilled tubes contain excess citrate, which can actually cause prolongation of clotting times. But not all assays are affected equally. This is data from a study that was published looking at 5 assays: the PTT, the PT, fibrinogen, activated protein C resistance, and factor VIII activity, and they collected tubes at full draw, 89%, 78%, and 67%. And so the assay that's most greatly affected is the APTT. The PT is not affected as much, but the current recommendation, and we'll talk about the guidelines in coagulation, is that we should not be accepting tubes that have less than 90% fill volume. For those of you in the laboratory know, sometimes that's very difficult to actually visually inspect because many times there's numerous labels on the tubes themselves. Clotted samples, so the presence of a clot in a sample regardless of the size, is a frequent reason for rejection. So this is probably one of the top reasons that we reject samples in the hemostasis lab, because clotted samples indicate consumption or activation of clotting factors and platelets. And so depending on the clot, you may see a prolonged PT, APTT, and thrombin time, and that's if fibrinogen is actually consumed by the clot. You can see shortening of the APTT, and that is if the sample is activated but fibrinogen is still present, and often you'll see an elevated D-dimer. So historically, it's been standard practice to check for clots before centrifuging our samples by uncapping them and then actually introducing 2 wooden applicator sticks into that sample. But that's really no longer recommended because that's actually not a practice that's ever really been validated, right? What do 2 sticks do when you put them in a coagulation tube? I don't think many people know, but there is a risk of activating samples, there's a risk of contaminating samples. So instead, what's actually recommended is gentle inversion and visual inspection to detect. Again, when you have 5 labels on a tube, that's very difficult to do. So other pre-analytical variables that we need to keep in mind are what we term HIL, or hemolysis, icterus, and lipemia. And that's really, to understand this, we need to know the effect of these interference in our hemostasis assays. And to do that, we have to know the absorbance peaks. And Jack is going to introduce to you the top family optical system to better understand this in his presentation. But lipemia, shown here in gray, has a peak at about 300 nanometers and it actually tapers down at 660 nanometers. Hemoglobin shows 2 peaks. The first peak at 405 nanometers and the second at about 550. And bilirubin shows 1 peak with a maximum absorbance of 470 nanometers. So in the presence of an HIL interference, if you're using an optical system, you can have high baseline absorbance values that will be detected by the instrument, depending on the wavelength at which that instrument reads. And so Jack will discuss this more in his presentation. Hemolysis, once you've excluded in vivo hemolysis, poses probably the most serious problem for us in the laboratory. And that's because there's both analytical and biological interferences. So hemolysis is most commonly identified through visual scrutiny after centrifugation. So when I left Emory, we had these charts, and anything above 4 was rejected. But as you can imagine, there's a lot of inter-individual variability in assigning a value to a hemolyzed sample. And this has been demonstrated in the literature. The agreement between visual grading and the measurement by an automated hemolysis index is moderate, but probably pretty poor. So in this publication, in a single center, hemolysis rates were 8% by visual inspection, but for those same samples was 3.4% by the H index, which means that we would have accepted more samples for testing using the automated method versus by visual inspection. Not only is hemolysis an analytical problem, it also has biologic effects. So analytically and or biologically, you can see prolongation of the PT, you can see prolongation or shortening of the APTT, you see decreased levels of fibrinogen activity, increased levels of D-dimer, and decreased antithrombin. And so there are instruments that do use mechanical clot detection that don't have the optical interference, but really the results for any coagulation assay can be inaccurate because of activation or inhibition of hemostasis by cell lysis products. So when the red cells break, they release membrane phospholipids, other intracellular enzymes or proteins, adenosine diphosphate, and other substances that can actually biologically impact hemostasis. Icterus occurs when the bilirubin levels increase above 1.5. And so this is an in vivo condition. It can have multiple etiologies, but most commonly is present in patients with liver disease. Unlike hemolysis, this interference is mostly attributable to the spectral overlap at which some analyzers read. So it has a high absorbance, which, as we talked about, between 400 and 520 nanometers, and that peak is at 456 nanometers. So there is no optical interference in assays that read above 550. And again, Jack will talk about the optics of the top family system. Lipemia can occur for many reasons. Typically, you see this turbidity when there's an excess of triglycerides, an excess of 500. Can be caused, it's multifactorial, so you can see physiologic causes, like in the setting of postprandial metabolism, which is why most testing is done fasting. Paraphysiologic causes, if there's administration of IV lipids, like in TPN, or total parenteral nutrition in some patients. Metabolic disorders, like in diabetes, chronic alcohol abuse, impaired renal function, and pancreatitis. And it's also associated with some medications, which include treatment with protease inhibitors, estrogen, and steroids. So the use of these samples for the lab carry some analytical and clinical problems, but they're probably the least frequent sample type with the pre-analytical problem that we see. But the effects that we see for hemostasis specifically are analytical and biologic. So the analytical changes can be due to the light scatter, the reflectance, or their absorption due to the lipids. It can cause high baseline readings if the assay is read at 405, but it's probably not significant with analyzers that have wavelengths greater than 650. The biological effects of hyperlipidemia include elevation of factor VII. They have an acute effect on platelet function. It can decrease some clotting factor activities, including factor 2, 9, 10, and 12. And you actually also have lower levels of plasminogen activator inhibitor 1. So we do have guidelines on how to handle pre-analytical problems in the clinical laboratory. So there are ISO standards, which these are international guidelines to improve quality, specifically for the clinical laboratory. And they cover total quality management to reduce the frequency of errors. These guidelines focus on several areas, including administrative, technical, which has pre-analytical, analytical, and post-analytical regulations. So the specific ones related to what we're discussing today, ISO 5.5.3, which is documentation of examination procedures. So this would be documentation of interferences, HIL, drugs, or other cross reactions. There's ISO 5.8.2, which is report attributes, so that your report actually comments on sample quality that may compromise the examination result. And then ISO 5.9.2. So if the laboratory has a system for automated selection and reporting of results, that it has a documented procedure to indicate the presence of an interference. So anything that would alter that specimen and that result. We're all probably more familiar with the CLIA guidelines for hemostasis specimens. So this is document H21-A5, specifically on coagulation and molecular hemostasis assays. So currently these guidelines recommend rejection of samples that are clotted, collected in the wrong anticoagulant, have a wrong blood to anticoagulant ratio, so those that are under or overfilled, those that are unlabeled or mislabeled, those that are collected and stored in containers with other than a non-activating surface, severely hemolyzed, whole blood samples that were frozen before processing, whole blood or plasma samples for PT that were refrigerated before testing, and whole blood samples for von Willebrand factor, factor VIII analysis that were refrigerated before processing. So specifically to dive into the ones that we're going to discuss today, so clotted samples, so clots, especially microclots, may not be detected by the current methods that people are using, including gentle inversion or the stick method. That is a limitation that we currently have in the laboratory. The other thing about is 90% of the fill volume is recommended, and that is currently a clear recommendation. And the last being that grossly hemolyzed samples should not be used, but there is no qualification of what grossly hemolyzed is or what that equates to. The other thing that comes up and I get asked frequently about is lipemic samples and ultracentrifugation. I think many people confuse ultracentrifugation with microcentrifugation. Most of us in our labs don't have an ultracentrifuge. That's a dedicated piece of equipment. And actually ultracentrifugation can cause precipitation of large molecular weight proteins like fibrinogen, factor VIII, and von Willebrand factor. So some people use microcentrifugation to do this or other organic solvents that actually clear the lipids. However, the current CLSI recommendation is that until published studies are performed or the laboratory actually validates the procedure, that methods that don't have the interference should be used. It's important to be able to detect that at the appropriate level before really proceeding with altering that sample. For those of you that are CAP accredited, there are additional recommendations in the CAP guideline, which are very similar, or the CAP checklist, which are very similar to what we see with the CLSI document. So the lab should have a written guideline for rejection of under or overfilled collection tubes. It meets the same criteria that we've already discussed, with 90% of specimens having the correct volume being 90% of the fill volume. There's also a checklist item for that coagulation specimens are checked for clots before testing and reporting of results, so that is a checklist item. And so what we're going to talk about now is how there are technological advances in the hemostasis lab that actually lets us automate much of these checks, so they're not done by visual inspection or methods that have not been formally validated. And so we know that automation is very common in other areas of the lab. You can see it on the floor now, how many automated systems there are for clinical chemistry. Even microbiology now has mass spectroscopy, right, which I never thought would happen. But really in COAG we haven't made many advances until this analyzer family. So automation is now starting to embrace hemostasis testing. There are tracked systems. There are specific instruments to enhance reliability of testing. And I will now turn it over to John for his introduction of Jack. They're not done by visual inspection or methods that have not been formally validated. And so we know that automation is very common in other areas.
Thank you, Dr. Winkler, for that informative presentation. And now it gives me pleasure to introduce our next speaker, Jack Havlick. Jack has 40 years of experience in the field of medical diagnostic research and development. He has developed and worked in various diagnostic platforms in multiple professional academic settings. Mr. Havlick joined the R&D team at Instrumentation Laboratory 14 years ago, and where he's been contributed to the ACL Top Family 50 series platform launches. So with that, I'll introduce Mr. Havlick.
Thank you, and thank you, Dr. Winkler, for that excellent presentation on the importance of the pre-analytical phase in hemostasis testing, and also the issues. It's very critical, and there are a lot of issues still out there in terms of that phase. I have the pleasure of introducing the way that the TOP has addressed a number of those pre-analytical issues for the hemostasis on the new TOP Family 50 series system, which is the features are much easier to use than to actually pronounce. The highlight of them, are the tube fill height detection, which is the underfilling of the tubes, which everybody struggles with in the lab. And so that is automated. Thank you very much, John. The other is the abnormal sample aspiration detection of clots, possible clots in the sample probe that get introduced to the test. And then the last, the popular HIL, which is hemolysis, icterus, and lipemia. Okay, so the first one that the top addresses is the underfilled tubes. So current tubes that are approved for the top that you may be using in your lab, and a lot of different labs are using different collection tubes. You use those same tubes, and through a liquid level sensing on the sample probe, it's able to detect the actual volume in that collection tube. Okay, it'll alert you to the possible sample collection error. So as Dr. Winkler had pointed out, a lot of your collection tubes in the lab, even though we see a lot of pictures of a clear aliquot tube, the actual collection tubes has your vendor label, has your hospital label. It's already been spun down, so you have the packed red blood cells on the bottom. So to actually see that level and see the plasma level is very difficult. So this ensures that the anticoagulant ratio is actually correct, and it automates and standardizes that for you. It's able to detect. The second thing is the clot detection. Okay, so this is another area that is could be an issue and a problem in pre-analytical, and Dr. Winkler talked about that. This is actually a pressure transducer that is actually also on the sample probe. So again, nothing that you need to do. This is an always-on feature that will then alert you to a possible clot in the sample aspiration step. So that's actually the second issue that gets taken care of through automation in our new system. The next one is the popular detection of hemolysis, icterus, and lipemia. Again, it's the hemoglobin, bilirubin, and turbidity. So what the top does is it generates a sample-specific level for all three. So if you run a number of tests on a particular sample, it will generate those HIL levels once. So for that particular sample, and then it will use those levels for assay test-specific thresholds for any other test you run off of that sample later. Okay, so it's a test that gets run once, and then it gets used for all of the other tests that gets run off that sample. Again, a very difficult thing for people working in a laboratory to actually peek through those labels and see that plasma. The picture on the bottom shows the real nice clear difference between the different levels of lipemia and hemolysis and icterus, but to be able to see that in a tube, a collection tube, I'm sure everybody here has tried to do that in your lab, and do it from operator to operator, from day to day, in condition to condition, is a very, very difficult task. So what this feature does is it will automate that for you. The references for each one, which we call the thresholds, they're currently in your package inserts for each of the tests that you have. But what the new top feature does is that's already in the top. So for the test that you run, it'll already project that threshold. There's a complete list of all the thresholds that you can, instead of going to your package insert, which you will see on the top monitor. And to remind you again about the test-specific feature, so one test can flag positive for hemolysis. For the same sample, another test will not, and you can use it for that sample. Now, how do we do it? So how do we actually measure those three levels? It's actually in our optical reading unit. So it's as a sample and a test is being run. And yeah, right here, that's our ORU area. That's where the sample and the reagent is placed, and the start reagent is added, and the optics begin. for those first few seconds, there's multiple readings that take place per second of 671, 405, and 535. So it keeps switching back and forth. And like I said, it's approximately 10 per second, which is a lot of switching back and forth. So you get a decent amount of data to actually then take that information. It goes into some complicated multiple algorithms that then will spit out the level of hemoglobin, level of bilirubin, and the turbidity for that particular sample.
Right here,
all of this is automated.
That's our ORU area. That's where the sample.
Okay, and why those three levels? The reason for the three levels is turbidity at 671. Most of your interference, 99.9% of your interference is going to be from turbidity, not from bilirubin, not from hemoglobin. At 535, you have a combination of hemoglobin and turbidity, and then at 405, you have turbidity, hemoglobin, and bilirubin all contributing to that wavelength, to absorbance. So the algorithms, if you have those three levels, they can tease out each level, each of the three different interference. And again, then they are locked in for that particular sample, and any test that you run off of that sample will be used. Okay, so what is it going to look like to you in terms of the result? So on your result screen, if any one of those three interference is actually above your threshold for that test, you will get a little icon there alerting that to you. And also in the result, it will say hemolysis high, lipemia high, bilirubin high, icterus high is what it'll say. And then if you go deeper into the, some of you who are running a top now will know you can go into test details. And what you will see there is you will see for each test, you're going to see, you can't really read that, but that is hemolysis, that is bilirubin, and that's your lipemia. These lines here are actually your thresholds for each one of those tests, and this green area here is actually the value. So you see for PT for this particular sample, the level of bilirubin is here, but for PT, because the threshold is so high, you could use that value. However, for FibC, the value is in the same area, but the threshold is much lower, so it's an alert to you that for FibC, the bilirubin is too high for the sample.
For each test, you're going to see, you can't really read that, but that is...
Okay, so along with the pre-analytical features, there are also some other features which happen after the analytical, basically in your post-analytical, which haven't been mentioned before, and they're listed above. So you have your current testing for your pre-analytical checks, but then you also have an enhanced security, which allows the individual to assign an ID, password, and access restrictions, configurable operator, expiration, and log-off settings. And then for accreditation and your audit trails, which are always very, very important. So you want to make sure you get the right results, but then you have to store those results and show those endlessly to people. This area is actually pretty good. It generates automatically the predetermined date and time to meet laboratory documentation schedules, and the audit trail also has reports that you can add your e-signature to.
But then you also have enhanced security,
and
which
that takes us back to Dr. Winkler.
ID, password, and access restrictions, configurable operator, expiration.
So I just want to close this presentation with sharing with you a case study that was performed with the Top 50 series. This is a health economic study that was done in Legnano, Italy. And so this study was to examine the health economic benefits of automating pre-analytical sample checks. So just to give you some background on this facility, so this is a 600-bed hospital. It's located just outside of Milan. They do 146,000 routine hemostasis samples annually. And the design was really to test the number of samples over a 2-week period using their gold standard method, which was their lab protocol visual inspection, versus the HIL checking, the tube fill height check, and the clog detection on the top 50. And so samples were categorized as either accepted or rejected. And so in that 2-week period, they examined the results of over 5,000 samples that were tested for PT, APTT, fibrinogen, and D-dimer. And so what I want to share with you today is the results of that. So if you look at the top 50 series versus visual inspection, there's obviously we're expecting samples to disagree. I've already shared with you the data that was discrepant between visual inspection of hemolysis and the automated H-index. But of the samples that were accepted, so in this quartile, that were also accepted by visual inspection and by the top, so over 4,900, those that agreed on the rejection, 54. Importantly, for visual inspection, they would have rejected 70 samples that were accepted by the top. So acceptable to report those results. So you can imagine if that patient came back to have to be redrawn to have those when those results were initially accepted. But there were 5 samples that were rejected by the top that were accepted. So we don't know what that actual risk is of those results just by this study. So 8.5% that had a pre-analytical issue identified were not detected visually. And there were 52% reduction in sample redraws. So from this here, this is annualized data, before the top 50 to after the top 50, the number of redrawn samples before was over 3,500, and that would have been reduced to 1,679. So you can imagine the cost associated with the redraw. So that cost went from estimated US dollars of $22,666 to $10,695. So by doing automated checks, that cost savings, which was annualized, was over $11,000 just by implementing this technology. And that's just redraw time. So that's not patient satisfaction, things that we get graded upon, patient outcomes, etc. So in addition, there was a 70% reduction in staff time by implementing automation. And so this was another big benefit of using the top 50 series and automating the pre-analytical checks for tube fill height, clog detection, and determination of HIL at the assay-specific level. So just to conclude what we went over in this symposium, but pre-analytical errors are the leading cause of laboratory error, and they're always going to be problematic for us since we have no control over that phase of testing. In the hemostasis laboratory specifically, in order, hemolyzed, clotted, and underfilled samples are the most prevalent errors, but there will be challenges with icteric or lipemic samples as well. Those will always remain. So automation in hemostasis is entering a really exciting time because we can now do systematic assessment of sample quality, which has never been done before. And that implementation of this technology in the hemostasis lab in a case study has shown reduction in the number of rejected samples. It's resulted in decreased technologist time, samples recollected, and cost. So just to conclude...
Thank you very much, Dr. Winkler and Jack. At this time, we're going to open up the floor to any questions that you may have. So if you will, we have microphones moving through the audience.
Thank you very much. This is a very good review of these problems. Currently, you don't have the patients around. Maybe he is from far area. So is there any way that you can use some of that sample by having a formula or something to utilize the same samples to do some tests?
So because the thresholds are assay specific, say you have a sample that has 5 tests, a PT, PTT, fibrinogen, D-dimer, and antithrombin. Say only one flagged, you could report the other analytes for that sample. So you might not have to bring that person back to recollect, say if that assay was not clinically specific to the management of that patient.
Plus, another point on that is you actually noticed the slide was kind of busy, but you actually see where the threshold is relative to that area where the result is. So you can see if you really need that test and that value is way out, then you would want to call somebody in. But it gives you a feel as to where the actual concentration is and how close to the threshold it actually is.
And maybe I can add just one more point here. All of those thresholds are established from our package inserts, but they can be modified to your laboratory's particular individual requirements for any of those. So you may in your laboratory wish to use slightly different or altered thresholds, and that's perfectly acceptable.
So do I assume that if it detects the level of the blood volume is less or is underfilled, does it still perform the test and gives out a number, or will it stop and not do a certain level?
Okay, so that again, that's a flexible point for your particular lab. Of the three, of the HIL, the underfill, and the clot detection, the only one that overrules you is the clot detection. The clot detection is always on. All of the other features are how your lab wants to use them. You know, they fit into your management. We're hoping that it's a powerful tool that you can use in the way you currently manage samples. So yes, it could flag it, or it could not, depending on your.
So what the top 50 does is it gives you the tools, and then you can select your own process on how to handle the tools that are in the instrumentation.
Could you elaborate a little bit more about the clot detection? I'm asking because I'm familiar with this with the whole blood, aspiration sensors, but in coagulation where the sample is spun down, oftentimes the clot is found sunken down in the cell layer. I'm just wondering, how is it accomplishing in the plasma layer detecting the clot? Unless occasionally it's like a fibrinous type gel, but often it's not.
All of the other features.
Well, as I was saying, it's a pressure transducer that's actually in the sample probe. So it happens during the aspiration of the sample. It doesn't sense anything else in the tube. It senses what you draw to add for that particular test.
If I can add to that, Jack, I think the key point here is that it is clog detection. So by being clog detection, we're detecting that the sample probe is obscured by typically a microclot or some other fibrinous clot. We do not say clot detection because there could be clots, as you know, in the cell layer down in the red cells, and those we would not be able to detect with this technology at this time.
I was wondering about the underfill. Dr. Winkler mentioned that there's like a 90% that's acceptable. Does your underfill hit that 90%, or are you like it's just below your level? Do you use that 90% with your underfill detection?
Okay, so remember, so you wanted to know if the 90% is hit or not with the current way to do it. It's remember, it's configurable to your particular tube. So it's not any tube gets thrown on and it's a 90%. So it's configurable to yours. You could set your tube to 90%. You could set yours to 80%, 95%. So that is also a configurable option for you. We would recommend it would be 90, but you could set it at whatever level you would like to.
Again, on the underfill, your instrument, do you have did you do your studies based on different types of tubes? Your tubes, you were saying is configurable. Like if we use just the Becton-Dixon tubes for it, how do you set that up? Like a different tube, when you centrifuge, it might have a different...
For the height, for the tube fill height?
Yeah.
For the underfill tubes?
Yeah.
Okay, so the underfill tubes, whatever tube your lab is currently using, there would be a one-time adjustment to set it to whatever level you think is correct. Let's say it's 90%. So then when that tube gets used over and over again, it uses that particular setting. And then if you want to change the setting or change the tube, then you reconfigure it and you go to the other tube.
Some things may be easier to explain if we showed you in front of the instrument. So please feel free to come back to see us at booth 801, and we'd be glad to show you exactly how it works.
About 700. This will be available on 700?
No, the existing 700, as you mentioned, is being supplemented by the 50 series. These are technologies available only on the ACL Top 50 series. So the 750, 550, and 350 series of analyzers that have just come to the U.S. market and have now also just been released into the Canadian market.
Any plans to update the old ones?
No, unfortunately, no.
For the height.
Okay. So in closing, first of all, I appreciate all of the questions. I wanted to remind everyone that there will be the PACE credits for this, so please be sure to take the information with you and apply for your PACE credits. And I would like to close the program by thanking Dr. Winkler and Mr. Havlik for their excellent informative presentations. And on behalf of Instrumentation Laboratory, I'd like to thank you, everyone, for having come to our presentation today. You're all welcome to please come by our booth, 801, to take a look at the ACL Top Family 50 series and our complete offering for the laboratory. And we thank you all for having come today. Thank you.